अच्छा थोड़ा मैं मैं वेट करता हूँ फिर, ठीक है। Hi students, how are you? I hope all of you are here for the class, and those who are seeing it live, wonderful. I'll be looking forward to your questions here, and those who are seeing it in a recording, you can always see the chat which has happened while we were doing this discussion. So good, welcome for the Farre sessions, and we are going to discuss a few topics. You know, I've been given a few topics which I thought are good for the final years before they go for the exams, and also I feel it will be a good quick fire revision for all these topics. I've picked up a few random topics, obviously. While we do the discussion, there will be some contraception also, there will be some CA cervix, CA endometrium, and you know, we'll be talking about fibroids, endometriosis. Today we're talking about physiology of pregnancy. So I've got some topics which are coming in exams regularly, and you know, I would expect that if you see the topics, you come with your doubts before, you know, before itself. If you have a reading of these, then you'll be able to ask me more doubts. So it's always nice to be a little prepared before you come for these revision kind of classes. So yes, let's start with the physiological changes in pregnancy. I'll try to limit my class to the changes. I'm not getting to puerperium today. Puerperium is also an important topic. Let's see if we can do that also some other time. But right now we are discussing about the physiological changes in pregnancy, and we'll start from the most important organ because I'm an obstetrician. So I'll start with the uterus. A non-pregnant uterus, if we see, is a size of 70 grams. So when the woman gets pregnant at term, you know, the uterus is as big as the coming till the xiphisternum. So when it is coming to the xiphisternum, it is 40 weeks. Now that uterus has a baby also inside. So the baby weight I'm just taking off, that is 3.5 kg, whatever. But the weight of the uterus alone at term is 1100 grams. So 70 and then it becomes 1100 grams. So what is the reason of this rise in the weight? The reason of this rise in the weight is the hypertrophy. Hypertrophy, okay? And that is because of the estrogens. Remember, hypertrophy because of the estrogens. And yes, it is also because of progesterones. They say there is some role of progesterones also. Now, what else I want to tell you here? In addition to understanding that there is hypertrophy of the uterus, please remember that after the pregnancy is over, delivery is done, then the uterus goes back to its normal size, correct? So the uterus, which was 70 before pregnancy, during pregnancy it became 1100 grams at term. Just the weight of the uterus is 1100 grams, and after delivery it should go back to 70 grams. No, it doesn't go back to 70 grams. It goes back to 100 grams. The least it will come back to is 100 grams. So what I want to impress by this bit of information, I want to impress upon you guys that please understand that from 70 to 1100 it is hypertrophy, correct? But there is some hyperplasia also, guys. There is some hyperplasia. That's why the weight is never back to 70. It will be around 100 grams. So we always, when we do a per-vaginal examination, we obstetricians know that whether we are feeling a nulliparous uterus or a woman who's delivered. So we say it's a multiparous uterus. She's not pregnant. Let's say she's have 2 children and the last child is 10 years old. But if I do a PV of a lady in the OPD, I know she's a multiparous woman because the uterus will be a little bit bigger than the size when she was a nulliparous woman. So there is hypertrophy mostly, but there is some hyperplasia also. They keep asking you these bits in the MCQ exams. Yes, you'll be enough for your MBBS exam that it is a hypertrophy. That's enough. All right, let's go. I'm sure you know all these details. We are supposed to actually do a revision here. So we'll just tell you how does the uterus enlarges. So I've already drawn it here so that we save some time. So uterine enlargement, the uterus is globular and spherical by 12 weeks of gestation, and then it is palpable in the abdomen by 12 weeks. If you see this one, this picture inside, this is the normal size uterus. Now this is the symphysis pubis here, and the uterus is just above the symphysis pubis and palpable at 12 weeks. And then it is at the level of the umbilicus at 24 weeks, and then it has the level of the xiphisternum at 36 weeks. Now after 36 weeks it cannot go higher anymore, so it starts filling up the flanks of the mother, the sides of the mother. So the flanks start getting filled up, and that's why we say now it is 40 weeks, because the uterine height goes down. the height goes down, but the flanks start filling up. So when the flanks fill up and the height goes down to 32 weeks, we say the woman is at term now. So for saying term, the flanks should be full and the height should drop down a little bit from this xiphisternum. Remember, the sides, the flanks get filled up. Right, guys. So let us see, how does the uterus come back to its normal size? How does the uterus increase? We've seen now. How does the uterus come back to normal size after delivery? That has become an even more important question. So after delivery, uterus is felt just below the umbilicus. Massive MCQ. Just below umbilicus. Now, what is the importance of this? This is what is going to come in your table viva. When a woman has delivered, the uterus is just below the level of the umbilicus. Why is it important? I'll just try to show you something. I'm putting a phone into my shirt and showing you. See, she's just delivered and I can put my hand on the abdomen of the mother and feel the uterus. She's delivered in the morning, evening I go for the rounds, I can feel the uterus. Why am I so happy about feeling the uterus like this? Because now, if she has delivered 2 children, tomorrow morning I can go and I can make a small incision here and get the tubes very easily. Yes, the uterus is an abdominal organ after delivery. So when the uterus is an abdominal organ after delivery, I can do something called a very easy tubectomy. So these are the fallopian tubes. We can make a small incision and with this small incision go and ligate these tubes very easily. Otherwise, you look yourself, the xiphisternum is here. Suppose the woman is, let's say, she's 30 years of age and she's got 2 children. The last child was born 5 years back. She come to me, sir, I don't want to have any more children. Please do a tubectomy for me. So if you have to do a tubectomy for a woman in regular days, not in the postpartum days, in the regular days, last child was 5 years born, then the uterus is inside the pelvis. So you will have to make an incision above the pubic symphysis and go so much deep inside to ligate the tubes. It will be difficult. It will be a much bigger incision. But when the uterus is in the abdomen, it's a very easy small incision and you can get the tubes and do a postpartum sterilization. So just below the umbilicus, it's a good time. It's a good time to do a puerperal or postpartum sterilization. A tubectomy surgery is very easily. Now, related to this, they'll ask you other questions. Why is this information good that the uterus is just below the umbilicus? You can do an easy tubectomy. How long can you do this tubectomy after delivery, the easy tubectomy? How long can you do it? You can do it as long as the uterus is in the abdomen. So the next question is, how long is the uterus in the abdomen after delivery? In other words, when does the uterus become a pelvic organ? Guys, if you've not understood, please stop, rewind and hear to this again, okay? When does the uterus become a pelvic organ? A major MCQ. Don't say 6 weeks. Uterus becomes a pelvic organ in 2 weeks. So yes, when it becomes a pelvic organ, you can no more do a puerperal sterilization. So puerperal sterilization can be done very easily because the uterus is an abdominal organ after delivery. She delivers today, tomorrow morning you can post her to the OT and do a sterilization. How long can you do it? You can do it for 5, 6, 7, 10, 12 days, but not beyond that, because now the uterus becomes a pelvic organ again. Pelvic organ in 2 weeks. When does it become a normal organ again? It becomes a normal organ again in 4 to 6 weeks. It becomes a normal organ again in 4 to 6 weeks. So these are the questions which keep coming in your exams and in your table vivas, guys. Very practical information, right? Good. Harsh is giving the answers. Some Hindi also, but my Tamil friends and my Telugu friends are going to get angry with me, guys. So ठीक है, I can talk in Hindi थोड़ा-थोड़ा बीच में, but फिर मुझे तमिल में भी बोलना पड़ेगा, guys. So I'll try to stick in Hindi for the time being and more English. Chalo, let's move on and see. After delivery, this is what happens. Then, after delivery, what is the weight of the uterus? मैंने आपको बताया कि the uterine weight is around 1100 grams at term. 1100 grams at term, just the weight of the uterus. Baby weight is 3.5 kgs. So at term it is 1100 grams. What is the weight of the uterus on the day of delivery? That means 1100 grams. So how does the weight reduce? Again MCQs. At 1 week, the uterus is approximately 500 grams. And 1 week later, again, it is about 300 grams. And then again after 2 weeks, it is something like 100 grams. So on the day of delivery, 1100 grams. 1 week later, half of that, 500 grams. Another 1 week later, half of that, 300 grams. Then 2 weeks later, it is half of that, it is 100 grams. Yes, sir, this is some abnormal mathematics which I'm trying to teach you. 1100 ka aadha 500, 500 ka aadha 300, 300 ka aadha 100. So pardon my mathematics here, but this is how I generally remember it very easily. So 1 week after delivery, it is 500, 2 weeks after delivery, it is 300, and 4 weeks after delivery, it is 100. Please remember, this is the most favorite MCQ in the exams. What is the weight of the uterus after 2 weeks of delivery? That is 300 grams. And please remember, it is 1 week, 2 week, and 4th week. Not first week after delivery, second week, third week, and 4th week. No, I didn't say that. First week, second week, and the 4th week. So how I remember? 1 2 ka 4, 4 2 ka 1. My name is Prassan. All right. Chalo. आगे बढ़ते हैं. So we are talking about uteroplacental flow next. Uteroplacental flow 36 weeks. Ab uteroplacental flow is 36 weeks means around 550 to 750 ml. Now uteroplacental, please don't get confused. There are 2 uterine arteries. Each uterine artery is giving 500 ml of blood. See, this uterine artery is giving 500 ml of blood. This uterine artery is giving 500 ml of blood. So if they ask you uterine artery per se, one uterine artery, how much of blood it is giving to the uterus? 500 ml per minute. But both these uterine arteries go and give blood supply to the uterus and to the placenta. So uteroplacental flow is up to 750 ml per minute. So we roughly say 750 ml to 800 ml blood is there in the uterus at any given time. So iska importance kya hai? What will happen because of this so much of blood in the uterus? It is good for the perfusion of the placenta, correct? But we also have to remember that when the placenta separates, then the base of the placenta can bleed, and when the base of the placenta can bleed after delivery, PPH, she can lose 800 ml blood in every 1 hour. Yes, she can, 1 minute, I'm sorry, she can lose 800 ml in every 1 minute. That's the kind of flow happening. That's why after delivery we keep saying contract karo uterus ko, contract, do a gentle uterine massage. That's why massage is important, guys. Massage karna hai. If you're saying no massage, then I don't know what else are you going to do. Please, uterus has so much of blood inside. So when the placenta separates, the base of the placenta bleeds, and it can bleed 800 ml per minute. That's why we do active management of 3rd stage of labor. Give oxytocin at the delivery of the anterior shoulder, so that by the time the delivery is completed, the placenta is removed, the uterus will contract and squeeze, and the uterus will not lose so much of blood. And after delivery, you do a gentle massage. After the placenta comes out, do a gentle massage so that the contraction is promoted. Your oxytocin will act and your massage will promote contraction. So please do uterine massage. All you MBBS students and all you interns will also know it, I'm very sure. Interns also worked in the labor room. Without uterine massage, your PG won't let you have your lunch. He'll say, aaj teri punishment and no lunch for you if you're not doing uterine massage. Yes, you have to do uterine massage, guys. Gentle uterine massage, obviously. So that's about the uteroplacental flow. That's why we keep telling you this physiology, because it is important in the delivery. There are so many details about physiology. You can go on remembering them in details. You can go on remembering rat ke chale jao sab kuch. Application is going to come in the exams. What is the importance of so much of blood in the uterus? That this much can be lost in PPH. Other importance is after delivery, the uterus contracts. Yes. So when the uterus contracts, PPH has not happened. The uterus contracts. So all this 800 ml blood from the contracted uterus will go back into the circulation. And the mother will have extra 800 ml in the circulation. Achhi baat hai. It's good that she has 800 ml which was in the uterus has come to her circulation. It's very good. But if she is a case of heart disease and a case of hypertension, you don't want the uterus to suddenly contract, because so much of blood suddenly goes into the circulation, and a hypertension patient can have an increase in hypertension and she can convulse, eclampsia can happen. And a heart disease patient will suddenly have 800 ml blood going into her and she'll go into failure. So these are extremely important details. I know some of you guys are watching this because you have got an exam coming up on 17th. Please remember, this 800 ml which is there in the uterus is good that the uterus contracts and all that blood goes back into the circulation. But if it's a case of a heart disease and hypertension, do not give methyl ergometrin, because it causes sudden contraction and a lot of blood goes into the circulation. patient can go into failure because of heart disease and can go into sudden increased hypertension because of a gestational or chronic hypertension if she may have. All right, a lot of theory going on, guys. Chalo, let's make it a little light. Let's tell you some basic wala details which keep coming. Uterine massage, please tell once why it's needed. Sutta, remember, uterine massage, when you put your hand on the uterus and gently massage the uterus, massage will promote contractions. That's why it is needed. So, moment you take out, the baby comes out, you take out the plasma by control contraction, and now the uterus base, the plastral base, this plastral base is going to bleed. So, I want the uterus to contract fast. So, my massaging will promote contractions. That's why uterine massage is required. All right, please ask questions. Always good to ask questions. चलो आगे बढ़ते हैं. Cervix. Now some details, some पक्का details. हमारे हिंदी में बोलते हैं रटंत विद्या, or what we say in your Gen Z language. Some things you have to mug up, guys. Some things have to be remembered because they have to be remembered. So that is the details. The estradiol stimulates the growth of column epithelium of the cervical canal, and that is what is violet, reddish violet in color, which is known as a ectropion. And then there are these signs which keep coming in your exams. Chadwick sign or Jacquemus sign is the bluish discoloration of the cervix and of the vagina, obviously, not just of the cervix, because classically it is mentioned for the cervix, but it is also of the vagina. Look, the cervix is blue, the vagina is not going to be yellow. I don't know why you guys have a confusion, because you say, nahi sir, hamara books kehta hai ki it is only for the vagina. Please guys, the choices given in some MCQs I saw, vagina, cervix separately they had given choices, vulva also was given. Cervix, vagina will be the same color, obviously. They won't be two different colors, please. So please understand, it is classically mentioned. If you read your Williams obstetrics, it is classically mentioned for the cervix, and the vagina will also be blue. Chadwick sign, also known as a Jacquemus sign. All of these signs are seen around 8 weeks. Most of the signs, only Hegar sign, which is going to come next, is seen around 6 weeks. So Chadwick sign is that. Then what is the Osiander sign? Pulsatility in the lateral vaginal fornices around the 8th week of pregnancy. Pulsatility here in the lateral fornix. You put your fingers in the vaginal fornices, you'll feel some pulsatility. That is the Osiander sign, also known as the vaginal sign. Now, Hegar sign is the softening of the isthmus. See this isthmus, this area. This is, the area between the anatomical internal os and the histological. I've written histological internal os. So this anatomical internal os, histological internal os, between that is the isthmus, and this isthmus is 0.5 centimeters in size. This becomes 7 centimeters when the patient is in labor. It becomes the lower segment. Big discussion we've done about this in the menstrual physiology chapter, the basics which I've taken in the app. You must see that, okay? So 0.5 centimeters is the isthmus. It becomes 7 centimeters in a woman who is having labor, and now this isthmus in early pregnancy becomes very soft. How can you feel that softness? You can put your hand in the vagina and in the abdomen like this, one hand in the vagina, one hand on the abdomen of the mother, and through the abdomen and through the vagina you can go, and you can go through the isthmus, and you can actually touch your fingers through the isthmus. It is so soft. What can happen if you're not very careful? You may go a little high and press like that, and you may actually cause an abortion. So that's why I'm not a very big advertiser of Hegar sign. I would want you guys not to do it. Yes, I'm telling it on YouTube, and everybody is going to hear this. Whoever is a medico also is going to hear it, my friends and my seniors. But please, this Hegar sign, if you're not very careful, you can actually end up doing the rupture of a sac. Okay, so remember, can cause an abortion. So be very careful. If you can just read about this sign and finish your PG, I'll be happy. You don't have to try this. If you become a postgraduate of gynecology, don't try to go and keep doing the Hegar sign. Cervix will be soft in pregnancy. You and me know that anyway. Okay. For the sake of giving respect to the gentleman, we are remembering this sign. Okay. Hegar sign comes in your exam. Okay. Now that is the Hegar sign. Then what is the Goodell sign? Goodell sign is the softening of the cervix. So Hegar sign is the softening of the isthmus, and Goodell sign is the softening of the cervix. Again 6 to 8 weeks. But Hegar is at 6th week. Now, Goodell sign is softening of the cervix. What is Hartmann sign? Implantation bleeding. Now, you have to mug up a few details. What is Palmer sign? Rhythmic uterine contractions. 4th to 8th week of pregnancy. When you put your hand inside the vagina and one hand on the abdomen, and just keep your hands with the uterus between your hands. Don't keep pressing. Just feel the uterus between your hands. You will feel some rhythmic uterine contraction 4 weeks to 8 weeks. That is what is known as a Palmer sign. It is not the Braxton Hicks contractions. Braxton Hicks contractions come later, 16 to 18 weeks. Palmer sign 4 to 8 weeks. We are coming to Braxton Hicks. So, Braxton Hicks contractions, these are the painless. These are painless contractions. These are the painless contractions which are having an intensity of 5 to 25 millimeters of mercury, and this are lasting around 30 seconds to 2 minutes and usually infrequent, but during term they become something like 10 to 20 minutes. Very nahi hai, every 10 to 20 minutes. So, nearing term they can be more frequent. So, these are painless contractions. The women will come to me in the labor room, in the OPD, and they'll say, sir, my uterus around 16 to 18 weeks. Did I write that? I think I forgot. 16 to 18 weeks it starts. So, this woman will say, sir, my uterus becomes as hard as a stone. I'll ask her, is it painful? No, sir, it's not painful. And how does it go off? Sir, it just goes off by itself. Or if I walk, I get better. Or if I'm walking, I sit, it gets better. Both ways it works. So, it gets better by itself. It is not very painful. So, that is what is the crux of the discussion about Braxton Hicks. Painful contraction seen around 16 to 18 weeks, and it will be relieved by resting or by walking also. Both ways it works. So, it is not associated with cervical dilatation. That's why it is also known as false labor. So, it stops with resting. Some women will say it stops with resting. Some women will say if I walk around, it stops. Both works. And then also called the false labor, because these are contractions, but they are not associated with cervical dilatation. We also call them the practice contraction. The uterus is doing some practice to get into labor later on. So, these are painless contractions. Okay. What about the breast? Breast, we see changes, very important changes. The estrogen will lead to the formation of the glandular ducts, estrogen for the ducts, ED, and progesterones for the epithelium, PE. I know I have a dirty mnemonic here, but anyway, I'll give it a chance. Erectile dysfunction, premature ejaculation. These are the only two psychiatric disorders I know, guys. So, please remember them. So, estrogen for the ducts and progesterone for the epithelium of the alveoli. Then, prolactin leads to the formation of milk. Yes, the milk letdown is happening because of the baby being born, and then the baby suckles on the breast, and that suckling releases oxytocin, which causes the letdown. Yes, that is the letdown reflex. Formation of milk, prolactin. Now, please understand, the milk formation starts in pregnancy itself. The letdown happens after delivery when the baby suckles on the breast. So, yes, the milk formation starts, the colostrum formation starts as early as first 4-5 months. Thick yellowish fluid called colostrum, which is rich in IgA. Your pediatrician will teach you great detail about this. So, when you see that the breast will have some amount of colostrum coming out as early as 5th month itself. I'm not saying she's going to keep discharging milk. No, that will happen only after delivery. I'm saying formation starts. Yes, once the baby is born, the first 3-4 days, the milk is called colostrum, and that is the most important part of the milk for the baby, all that you know. When does the formation start? I'm repeatedly telling you, it starts forming as early as 4th to 5th month of pregnancy itself. So, areola become broader, and many small elevations are seen, which are hypertrophied sebaceous glands. So, on the edge, you'll see these sebaceous glands. Men, women both have these sebaceous glands, but they become hypertrophied. They become a little bigger in pregnant mothers. So, that is what is known as the hypertrophied sebaceous glands, also known as the glands of Montgomery. The glands of Montgomery. Montgomery tubercles. All right. कुछ नहीं पढ़ा, please guide. Circle MBBS first year के terms का tension हो रहा है. All right. Guys, people who are not getting tense because of an exam coming up, they are not reading. तो देखो, tension होना अच्छा है. थोड़ा सा डरना जरूरी है. If you're not scared, that means you're wasting your time. You should be scared of the exam. Then only you'll read. यार कोई बात नहीं, पढ़ते रहो. Even if you're tense, if you're not able to read and you're not able to understand, sit with your best friend. He's reading. Ask him questions. He'll help you. He or she will help you. So please understand that do not take an exam very cool all the time. ये जो तुम लोग का जेंजी वाला एक let it be cool यार, stay positive. अरे नेगेटिव रहो थोड़ा. नहीं पढ़ोगे तो फेल हो जाओगे ना. तो मैं तो कहता हूँ नेगेटिव रहो. एक दिन एग्जाम के पहले आके मुझे बोलोगे सर मैं पढ़ा नहीं हूँ. हाँ, स्टे पॉजिटिव. अच्छा है, यू गुड, यू विल पास. वो सब झूठा है. थोड़ा डरो, थोड़ा नेगेटिव रहो, तभी तो पढ़ोगे. पॉजिटिव ही रहोगे, सारा टाइम पॉजिटिव रहोगे तो डरोगे कैसे? इफ यू आर नॉट स्केर्ड, हाउ विल यू रीड? ये बहुत सिंपल सा प्रिंसिपल है लाइफ का. इफ यू आर नॉट वरीड, यू विल नॉट रीड. ठीक है, थोड़ा सा डरना चाहिए. इट विल पुश यू. And maybe if you're not doing good in this exam, learn from this experience that one day before the exam I was so tense. Learn from the experience. Let the experience drive a message onto you that next time I have to be better prepared, my friend. Next time I have to be better prepared. So ये भी एक education है. Yes, to get tense before the exam which you've not prepared for, it's an education that next time, bloody hell, I have to be better prepared. I was in a revision class, but I was asking sir about how to write an exam. I was not worried about what was coming on the subject. That's how tense you are. All right, chalo, let's get on to the subject because we have more work to do. Chaliye. So cardiovascular system. So cardiovascular system, what happens? The heart moves upwards because the increasing in the height of the size of the abdomen, the heart moves upwards and outwards. So heart moves upwards and outwards. And see this heart, can you see this is the mid-clavicular line? The mid-clavicular line, you generally see the apical impulse. But now what happens? The heart will move outwards. This heart will go outwards like this. So the apical impulse, the apex will go to the anterior axillary line. So you will hear the heart a little bit later and upper, the anterior axillary line. There is hypertrophy of the cardiac muscle. Cardiac output will increase. Now cardiac output starts increasing as early as the 5th week and it peaks at 32 to 34 weeks. So the maximum cardiac output, these MCQs keep coming in your exams. When is the cardiac output maximum? That's what we are going to discuss in the pregnancy and then in labor and then in delivery. So that's the most important chapter about the organs which we keep talking to you, changes in organs in the woman's physiology. And the cardiac changes are the regular questions which are asked in the exams. So this is a diagram inspired by Williams obstetrics. A non-pregnant woman has 5 liters of output per minute and a pregnant woman will have 7.1 liters per minute. And after delivery it will be 9.3 liters. So heart is having a lot of work to do around 30 weeks. Around 32 weeks, the heart is pumping a lot of blood because volume is maximum in the antenatal time. But now what happens after delivery? 800 ml blood is there in the uterus. Remember that 800 ml goes with the contraction of the uterus, that 800 ml blood goes into the circulation and that high volume will make the mother have a cardiac output even more. The cardiac output will be even more, 9.3 liters per minute. So yes, the heart works even more after delivery. That's fine. The mother is healthy. She can manage all of this. No problem. She is 5 liters in non-pregnancy, 7.1 liters at 32 weeks and first 24 hours after delivery, immediately postpartum, 9.3 liters. This is all normal physiology. Women are ready for this. They are prepared for this during the pregnancy. Everything is fine with this. Problem happens when she is pregnant with a heart disease. Then these times, the antenatal time 32 weeks and postnatal time first 24 hours become problem. So see here, cardiac output, maximum cardiac output in the antenatal time is 30 to 32 weeks. Maximum cardiac output in postnatal time is the first 24 hours. Cardiac output in patients will increase at these times. But if it's a case of heart disease, then cardiac failure can happen because the heart is not so good. Let's say it's a case of rheumatic heart disease and the patient is having mitral stenosis, and the mitral stenosis heart will not be working very well. It will be probably fibrillating sometimes. So that heart which is not working properly will have to suddenly work too much at 32 weeks, will have to start working too much in the first 24 hours. That's why cardiac failure happens in these times, in antenatal time 32 weeks and postnatal time first 24 hours. Solid in MCQs. And when you have your heart disease exams in the obstetrics, when you have this heart cardiac case, they'll ask you about these details, normal and what happens in a heart disease. Then what happens to the blood pressure? In the early pregnancy, the blood pressure reduces. Then later pregnancy, the blood pressure goes back to normal. It picks up. It goes back to normal. I'm not saying it increases. No, no, no. Normal is that in the early pregnancy, in the first trimester onwards, till the early second trimester, blood pressure is dropping. And by the late second trimester, blood pressure goes back to normal. Okay, this is what is the normal changes. Heart rate will increase. Stroke volume increase. Just now I told you cardiac output will also increase. But what does not increase? Let me just tell you. We're talking about the heart, but just to make you remember, respiratory rate, there is no change. This is, I have a habit of telling you MCQs all the while, because ultimately we are writing PG entrance now. So that's why I have a habit of telling you a lot of MCQs when we're discussing theories. So respiratory rate, there is no change. Okay, so heart rate increases, stroke volume increases, cardiac output increases, and mean arterial blood pressure decreases by 10%, peripheral resistance decreases by 35%. These are the two things which reduce. And MCI exam, they kept asking you this MCQ many times. And INICT, these two exams generally keep, adan pradan chalta rehta hai MCQs ka between these two exams, INICT and MCI. So mean arterial blood pressure, peripheral resistance decreases. What is the supine hypertension syndrome? When the mother is lying down supine, if you see the mother lying down, then the weight of the baby presses on the vena cava, and that reduces the venous return to the right heart. And when it reduces the venous return, the cardiac output reduces. Reduced cardiac output for the mother, she may feel a little giddy or a little sleepy, but it is not a major problem for the mother. It's a big problem for the baby. The baby will get hypoxic sometimes. 10% women, not all women, okay? So in 10% women, the weight of the baby, when it presses, it causes significant hypotension, which can cause hypoxia to the baby. So yes, supine compression of great vessels by the uterus, significant arterial hypertension, good enough to cause hypoxia of the fetus. That can also happen. Right, that's why we say that the pregnant mothers should sleep like this, on the left side or on the right side, one of the sides. So the weight of the baby will fall away from the vena cava. But also for the cesarean sections, the mother should not be like this. The mother should be like this, a little bit tilted, 15-degree tilted. Just today, around 4 hours back, one of my IVF conceived patients was having a cesarean, and God bless her, she had a tough time to have a pregnancy, and now finally she's on a very happy day today. And when the cesarean was happening, I went to the OT. Although I hardly get time to get into obstetrics these days, but I went to the OT. I was requesting the consultant, please give a lateral tilt. So the anesthetist was one of my students, old PG entrance student. She said, sir, I've given a lateral tilt. I'll never forget how you demonstrated in the class that you were turning. So I'm so happy that my students remember. She was anesthetist in the OT today, and she had already given the table a lateral tilt. Generally what we do, we don't have suppose a motorized table, so we put a wedge, what do you call, a wooden block under the buttock, and we give her a 15-degree lateral tilt. Or sometimes what we use, a IV fluid bottle, we put it under the buttock, and that's why it gives a lateral tilt. So yes, even during a cesarean, you should do this lateral tilt. See, when the baby is mother's supine, the baby's weight is pressing the vena cava here. If you can see, this is the vena cava, it is compressed. So if you give a 15-degree lateral tilt, see, the vena cava is now distended and it is not compressed. All right. Okay. Childbirth, yes, the milk is released only after childbirth, obviously, because you need the suckling reflex and the oxytocin. So yes, that can happen. But yes, lot of women who are pregnant for the second time, and the first child is only 1.5 years, so they are breastfeeding also during pregnancy. That it's not that it cannot happen during pregnancy. Some child has to suckle on the breast, and they will be milk discharge, but we don't advise it. It's a little controversial. We don't advise mothers who are pregnant to breastfeed the previous child. We don't advise. So breast milk production starts in pregnancy, and if really you ask me, can breastfeeding happen during a pregnancy? Obviously it can happen, but it's going to drain out the woman a lot, because breastfeeding requires a lot of resources of the mother's body. to make breast milk. So it's not advisable to breastfeed a previous child when you're pregnant for the second time. All right, I hope that answers your question. Cardiac output, I've already told you, cardiac output increases during pregnancy 30-32 weeks and during after delivery in the first 24 hours. So 50% increase in the 30-32 weeks, and after delivery 70% increase. That's why these two times when the heart work is more, if a patient is a case of heart disease, there is more chances of failure. I'm sure if you want to hear this again, it is already recorded. It will be there on the YouTube. So don't get upset if I've gone a little fast, because I was told it's a revision, right, guys? So we must finish things a little snappy way. I'm not going to rush through it. We are discussing with a lot of examples. We'll try to make use of this class. All right. So normal change in the heart sounds with pregnancy, then exaggerated splitting of the S1 because of the large volume of blood. So increased volume is the reason why there is exaggerated splitting. Loud and easily heard third sound, the S3, because of the rapid filling. There is rapid filling of the left ventricle. Rapid filling of the left ventricle is the reason why you'll hear the S3. And then 95% patients will also develop a flow murmur simply because of high volume of blood going through the aortic wall. So there'll be a systolic murmur also. These are all physiological changes. Hematology, another example, another organ which is asked a lot in your exams. So blood volume increases by 30 to 45% at 32 weeks of gestation. I told you cardiac output increases. That's because the blood volume increases. So this blood volume increase is because of the reduction in the threshold for thirst. प्यास ज़्यादा लगती है. She is thirsty early. நிறைய தண்ணி கொடுக்குவாங்கப்பா அவங்க அதுக்காக. So she's going to drink a lot of water because she's thirsty faster. So that's why more water goes in, and then she's got a sodium retention. So both these can happen. That's why there is more fluid. That's why there is more fluid in the mother who is pregnant. But we must understand a few more things, not just increased blood volume. We must think in terms of fluid and RBCs. Please look at this diagram very carefully. Red cell number increase, fluids also increase. But can you see the red cell number is increased, but the fluid amount increases much more in proportion to the RBC increase. Once more, see, if you look at these two diagrams behind me, yeah, fine. Okay, RBC volume increasing, correct. Fluid volume increasing, correct. RBC increases, fluid increases. But the fluid increases much more than the RBC increase. So what happens? There is more fluid rise than RBC rise. There is a net hemodilution in pregnancy. खून पतला होता है pregnancy में. So RBC amount increases, correct. They'll ask you a question. What is the net number of RBC in pregnancy? More. Net amount of fluid in pregnancy? More. But what about the RBC concentration? There is hemodilution because the rise in RBC is lesser than in proportion to the rise in the fluid. So there is net hemodilution. खून पतला होता है pregnancy में. So what is the benefit of that? Why is nature making the blood thinner in pregnancy? It is good for the see, hemoglobin drops here from 13, it drops to 11 g%. That is because the RBC is the blood is getting hemodiluted. I'm not saying less than 11. Less than 11 is anemia. So why is it good to have hemodilution? It is good to have hemodilution because I have written this here. It is good for the fetal perfusion. Can you see the uterine artery which is giving blood to the spiral arteries? If the blood is too thick, the blood will get static. There will be stasis of blood in these spiral arteries, and stasis of blood means there will be clotting of blood. So you want thin blood. So that's why the blood in the state of hemodilution will be good for the perfusion in the placenta and nourishment to the baby. Also, when delivery happens, when the baby delivers and the placenta is removed, the base of the placenta will bleed, and that time the blood is thin blood which is lost. There is more fluid loss than RBC loss in delivery. So very important, the blood in delivery is more fluid loss than RBC loss because खून पतला है. That's why nature has done a very wonderful arrangement that blood is thin so that perfusion is easy for a small early initial placenta. Number two, when the delivery happens, the blood loss is more fluid loss than RBC loss. That's why we say that there is a good arrangement to conserve the RBCs in pregnancy. All right, let's move on and see that there is decrease in the, just a summary, decrease in the red cell concentration. There is increase in the number of RBCs, but concentration reduces. That is what I told you just now many times. Hemodilution will happen in pregnancy. Now, hemoglobin concentration will also reduce. Hematocrit, which is another method of saying hemoglobin is less, and plasma folate concentration will reduce. But what will increase? Clotting factors will increase. See, WBC increase, ESR increase, but the clotting factors will increase in pregnancy. Why am I shouting now? When a woman delivers, the plasma delivers, and the plasma delivers, the base of the plasma bleeds, and the base of the plasma can bleed 800 ml in a minute. So you want more fluid loss than RBC loss, correct? So the blood is thin, more fluid is lost than RBC loss. That is one thing I already told you. Now, wherever the bleeding is happening after delivery, जहाँ पे bleeding हो रही है, वहाँ पे clotting ज़्यादा है कि कम है? There is more clotting or less clotting at the place? There is more clotting in pregnancy. Another wonderful arrangement by nature, that at the site of the bleeding, the base of the placenta, the clotting is much better in pregnancy. That's why we have a very good arrangement by nature. Thin blood loss is more fluid loss than RBC loss, and at the site of the bleeding, the clotting factors are more. So clotting will prevent more further blood loss. So all clotting factors in pregnancy are increased except 11 and 13. All those who are writing the exam on 17, this is likely to come in exams, guys. Clotting factors 11 and 13 are not increased. Rest all the factors are increased. There are 13 factors, out of which 11 are increasing. Only, I'm interested, total 11. Factor number 11 and 13 are not increased. All right. Fibrinogen levels, I'll just tell you, these may come in your NEET exam. That average is 300 milligram per deciliter in a non-pregnant woman. In a pregnant woman, it is increased by 50% and goes up to 450 milligrams per deciliter. Right, respiratory system, the chest will open up a little because the baby is coming up and the chest opens up. So the subcostal angle, this angle, if you see this subcostal angle here, this angle, this will increase. So from 68 degrees goes to 104 degrees, diaphragm rises by 4 centimeters, but respiratory rate, there is no change. I'm writing William says so that you don't contradict what I'm saying. Okay, so respiratory rate, there is no change. Vital capacity, there is no change, but the tidal volume increased by 40%. All right, so tidal volume increases, respiratory rate, vital capacity is unchanged. Mug it up, you can understand also easily. But what is more important? The functional residual capacity. It is the personal scuba tank. That's how I understand this. FRC is my personal scuba tank. Like when I hold breath, why don't I die? When I'm underwater and I'm not coming up for, let's say, 30 seconds, why don't I die? Because my FRC, my own oxygen tank, which is there, the residual oxygen in my lungs is keeping me alive. So that functional residual capacity, which is the expiratory reserve volume and the residual volume, that reduces 20 to 30% in pregnancy. Don't feel bad. Don't feel bad for this pregnant mother, because she increases her inspiratory capacity in pregnancy to compensate for the loss of this. So inspiratory capacity increased by 5 to 10%. So what is the net result? Total lung capacity, which is a combination of functional residual capacity and inspiratory capacity. FRC plus inspiratory capacity is the total lung capacity, and this is unchanged. So that's why therefore pregnant mothers are not hypoxic. Please remember that. Pregnant mothers are not hypoxic because the FRC has reduced, but the inspiratory capacity has increased. This will compensate for the loss of the FRC. So total lung capacity is unchanged in pregnancy. All right. I've tried to God, not nature. Okay, God, not nature. Okay, fine. That discussion is some other place. Nature is also under God's commands. So we'll do that discussion some other time, my friend. So for the time being, I think, I don't know what batao he's asking me, but you can ask me the question again later on, my friend. So right now, we'll just get into our other discussions. So, urinary system, kidney size increased by 1.5 centimeters and glomerular filtration rate increased by 50%. Now, this hyperfiltration is because of the hemodilution. Now, there is reduced protein and reduced oncotic pressure and increased renal plasma flow. These are things which you have to remember, but remember this part easily. The glomerular filtration rate increases. Why am I stressing on this part? If the GFR increases, that means the clearance of waste from the body will increase. What is waste? Urea. Creatinine is what is the waste. So, the waste is cleared faster in pregnant mothers. So, that is why the serum creatinine levels will reduce and the creatinine clearance increases. That is why serum creatinine is reduced. We will discuss that in the next screen. One more thing I have to tell, 155 milligram per deciliter. Mother has had just a bowl of rice with some dal and she has the sweet lassi and the sugars increase to 165. That itself will come in the urine and you will think maybe this patient is having diabetes. This kind of glucosuria can happen to a lot of pregnant mothers. It may not be abnormal because the threshold is reduced, right? I hope you understood that. No, obviously twins, the physiology gets more reverse. The anemia is more and the the uterine distension is more. Obviously, that's correct. You will have to ask me a specific question. We're not doing the twins class right now, guys. We're doing the basic discussion. But yes, in twins, it is still worse. Correct. So, serum creatinine, like I was telling you, serum creatinine levels will decrease and creatinine clearance will increase because the kidney's filtration is more. So, waste will go out more from the kidney. So, creatinine clearance is more, that is why creatinine levels are less in the body. So, bladder frequency will increase because of the the pressure of the pregnant uterus on the bladder. So, there will be more pressure and more urethral length because of the stretching. That is why frequency also increases. Now, what about the gastrointestinal system? That is what is also important. Pyrosis, heartburn increases, and there is a thought that in pregnancy progesterone is more and progesterone makes everything slow. Correct. I agree with you. Progesterone makes the person also lazy first of all. The mother wants to sleep most of the time. She is slowly walking and she is mostly in a sleepy this thing because progesterone makes a person very relaxed. So, the bowel also gets relaxed. What did I say? The bowel gets relaxed. The gut, the large bowel especially gets relaxed. So, that is why the pregnant mothers are constipated. The liver canaliculi movement is also reduced. The gallbladder duct movement also reduces. So, there will be some biliary stasis also. But I did not say that the gastric clearance is not changed. Gastric emptying time is different from bowel. Gastric means stomach. So, stomach empties in 4 hours like it does for all of us. We eat lunch at 2 o'clock and by 6:30, 6 o'clock, 4 hours later, we are thirsty again, isn't it? We are hungry again. So, 4 hours it takes for the stomach to get empty and it's the same 4 hours in the pregnant mothers. So, gastric emptying time is unchanged. Bowel is slow. So, yes, mostly your large bowel is reduced because of the progesterone. There is constipation, there is increased presentation of the hemorrhoids. Now, what happens to the liver function? SGPT, SGOT, gamma glutamyl transferase, all are reduced, but only alkaline phosphatase doubles. Alkaline phosphatase doubles up. Although the total albumin amount increases, but the fluid rise will cause the reduction in albumin concentration, just like the RBC I discussed earlier. And progesterone, like I told you, inhibits the cholecystokinin mediated smooth muscle stimulation. So, this progesterone will make the gallbladder and the biliary canalicular movement reduce. So, that is why impaired gallbladder contraction will cause the retention of the bile salts. So, that is why bile salts will be retained and bile salts cause the itching. Yes, bile salts itch, BSI, bile salts itch. So, retained bile salts because of slow movements, that retained bile salts, what? Cholic, phenodeoxycholic, these are the bile salts. Then bile acids, you should know, they are the combination of these bile salts with the glycine and the taurine. You must know all of that, okay? So, bile salts kya hai, bile acids kya hai, primary bile salts and secondary bile, you have to know all of this, okay? So, please read your biochemistry well, but remember that bile salts, when they are retained, they cause a lot of itching. So itching is not because of bile acids, it is not because of bile pigments, it is not because of bilirubin. Bile salts will cause itching. Bahut sari itching, that's the mnemonic which I am giving you here, right? Endocrine. Now before I go into endocrine, I'll just see some questions because bahut sari itching. Okay, medical traveler remembers that. Okay, fine. Why bowel slow hai? Because of progesterone. Progesterone causes smooth muscle relaxation. I told you that. Progesterone also, remember, progesterone is used for tocolysis also, for stopping uterine contractions. Preterm labor, progesterone is a tocolytic because it relaxes. We give a lot of progesterone tablets to mothers to prevent preterm labor and also to treat preterm labor sometimes. So yes, progesterone causes smooth muscle relaxation, that you have to remember. And that's what helps in understanding that the gut is peptin neurons, and that reduces the gonadotropin releasing hormone. So high prolactin reduces the kisspeptin neurons, and that's why the GnRH amount coming from the hypothalamus will be stopped, and that's why the FSH and LH will be reduced. That's why pregnant mothers do not ovulate. That's why mothers who are lactating do not ovulate. Very, very important. Okay. So this reduction is because of high prolactin reducing the GnRH. High prolactin reduces GnRH. So that's what I written in gonadotropins decline in number. This is a very important endocrine change. Right. How to fix this? Internet connection. Wait a minute. I think it's working now. I'm sorry if there was a problem. How does the fetus excrete? Fetus, see, fetus also excretes like us. Fetus will excrete. I did not discuss that in the class, so you didn't miss anything. Fetus will have no food in the gut. Fetus only has fluid coming to the body from the mother through the umbilical artery, and that umbilical vein, rather, the fluid, the blood which comes from the placenta goes to the baby, and that fluid will keep coming, and that baby is absorbing a lot of fluid from the mother's circulation. That fluid will go to the kidney, and the baby will excrete through the kidney. But the baby also has a gut which is made, and the gut will have epithelium. The epithelium will be shedding, and the gut will also be having some amount of bile coming in because of the gallbladder. So gallbladder will give some bile into the gut, and the epithelium will shed in the gut, and that will make that pasty meconium which will come out as stools. So these are the two mechanisms, stools and urine. That's what is the mechanism of excretion in all humans, including the fetus. So I don't know, maybe you want to ask me a special question. That's why. So doesn't matter. Your handwriting is not visible, so I'll not use red. Red was a problem I could see. I'll use black. Yes, thank you for reminding. I keep forgetting. So I'll use only black. Thank you. So this, you remember, the high prolactin reduces the kisspeptin neurons, that reduces the GnRH, and that is causing reduction of FSH and LH. That's why there is no ovulation. No ovulation in pregnancy and in lactation. All right. Then one more thing I want to tell you, that the corticotropes and the thyrotropes are constant in pregnancy, but the somatotropes are generally suppressed. Somatomammotropin, yes, the growth hormone stimulation. The growth hormone stimulation reduces. Why? Because the growth hormone which is made by the placenta makes a lot of growth hormone, and that will reduce the somatomammotropin. That's why the somatotropes are reduced in pregnancy. Again, you have to mug up a few things, okay? Corticotropes, thyrotropes are constant, but somatotropes are reduced. But the next one is most important, the thyrotropes. Now let's get into the thyroid function. Very important slide again. So please remember, the free T3 and free T4 are unchanged in pregnancy. Solid MCQ. free T3, free T4 are unchanged. The active form of thyroxine is unchanged in pregnancy, the amount. But what happened to the thyrotropin or TSH? Now, let us see that first. So, what happens in pregnancy? I'll just tell you. Before that, see this. Hypothalamus again, it acts on the pituitary by thyrotropin releasing hormone. Thyrotropin releasing hormone from hypothalamus acts on the pituitary, and pituitary will release what? Thyrotropin releasing hormone will obviously release the thyrotropin. It releases thyrotropin. I know you're screaming wherever you're sitting. Nahi sir, TSH boliye aap. Yes, it is also known as TSH. So remember this thyrotropin. That's why you'll remember thyrotrops. So if you know, increase your vocabulary, you don't get confused in the exams. That's my impetus in all my classes, that please remember synonyms. So I told you gonadotropin releasing hormone releases what? You say FSH and LH. No, you must say gonadotropin releasing hormone releases gonadotropins. What are gonadotropins? FSH and LH. Similarly, thyrotropin releasing hormone releases thyrotropin. So what is thyrotropin? A hormone which acts on the thyroid. Thyrotropin, it is also called TSH. So you must know the synonyms. So this will act on the thyroid. I know most of you know that, but some of you are in a hurry to read and you miss out on the synonyms. So thyrotropin releasing hormone acts on the thyroid gland, and the thyroid gland will get stimulated to make the thyroxine. Now, what happens in pregnancy? In pregnancy, there's a formation of a placenta, and the placenta makes the HCG. Are you able to see this? No, we'll stick with the black. So the placenta makes the HCG. This HCG, remember, the alpha subunit of HCG is same as the alpha subunit of TSH, is same as the alpha subunit of LH. Please remember that very important part of your basic biochemistry. Alpha HCG is same as alpha TSH is same as alpha LH. So we are keeping this in our mind. So the alpha subunit of HCG from the placenta, this will come and directly stimulate the thyroid gland. So the thyroxine will increase in production because of this alpha HCG acting like the alpha TSH. Now the thyroxine will increase, and this high thyroxine will give a feedback message to the hypothalamus, and hypothalamus will reduce the thyrotropin releasing hormone, which will reduce the TSH or thyrotropin. Extremely important, guys. This is coming in your INICT exam nowadays. So the HCG from the placenta stimulates the thyroid gland to make the thyroxine. Thyroxine is high, gives a message to the brain that there is enough thyroxine, don't stimulate me anymore. The thyroid is telling the pituitary, मेरे को धक्का देना बंद करो. So this high thyroxine tells the brain to stop the TRH. So TRH reduces, so that's why the TSH reduces. So in pregnancy, TSH reduces. Yes, that's why they'll ask you what is the level of TSH in pregnancy. You and me, if we ask, the upper level of TSH should not be more than 5. In pregnancy, it should not be more than 2.5, because the TSH is not required so much in early pregnancy, because the placenta is giving HCG, which is stimulating the thyroid gland to make the thyroxine. Yes, stop, rewind and re-listen to this part. Alright, please remember, TSH is reduced in early pregnancy because the placenta has high HCG, and the high HCG is there only in the initial few months, that is 9.5 weeks of pregnancy. The HCG is high, so that high HCG is stimulating the thyroid gland to make the thyroxine. That's why there's a feedback which reduces the TSH. I've told this many times here. Right, guys? So HCG, I've written that also just for you want to remember this. So HCG has intrinsic thyrotropic activity, and that high HCG will cause a stimulation of thyroid, and that's why the TSH reduces in early pregnancies more than 80% of patients. So normal TSH levels in pregnancy are less than all of us 2.5 international units in the first trimester and 3.5 international units in second trimester. You and me, normal adults, in normal adults, it is up to 5 international units in normal adults. All right. Right. That's what I wanted to teach you about the physiological changes. You can ask me some questions. A lot of you ask me a lot of things, and will you give any lecture for this January FMG? Yes, we are coming on 9th. On this 9th, we are having a big marathon discussion. Not marathon, don't think 9 hours, 10 hours. Good enough time for your discussion of all the gynae MCQs. Don't miss out on that, guys. I've sent it on a lot of forums, but yes, sometimes I may not be able to put it on all the sites. So you'll have some advertisements coming up now. So there is a proper FMG exam revision on 9, 6 p.m. Okay, we'll be doing all the MCQs. Do not miss out on that, guys. Yes. Endocrine part, tell again. Sutta Prasmanta. Which part? You tell me. Endocrine, which part? Which one do you want me to tell? This one? Okay. Yes. 6 p.m. guys, 6 p.m. 6 p.m. on 9th. Okay, this part you want? So yes, once more, just for my good friend here. So remember, okay, I'll tell you about this one also first then. Okay, here. So first, I'm telling you about the GNR relation. Hypothalamus acts on pituitary by gonadotropin releasing hormone. The pituitary will make FSH and LH because of gonadotropin. Pituitary also will make the prolactin. Prolactin will act on the breast. Breast will be stimulated to make milk by prolactin, which you know. But this high prolactin gives a message to the hypothalamus to reduce the kiss-peptin neurons. The kiss-peptin neurons are used to stimulate the GnRH release. So you reduce the kiss-peptin neurons, so GnRH will be reduced. The high prolactin reduces GnRH. GnRH reduced, so there is no LH and FSH in pregnant mothers. That's why they don't ovulate in pregnancy. And also after delivery, the mothers are breastfeeding the children. That's why they don't ovulate during breastfeeding also. Okay, that's one. Number 2. I was telling you about the thyroid function. So hypothalamus acts on the pituitary by thyrotropin releasing hormone. So when the TRH reduces, okay, fine, I'll go the other way. Hypothalamus acts on the pituitary by thyrotropin releasing hormone. This pituitary will act on the thyroid gland to make the thyroxine. So thyrotropin releasing hormone acts on the pituitary to release the thyrotropin, also known as TSH, which acts on the thyroid gland to make the thyroxine. Now, what happens in pregnant patients? That the plasma makes alpha HCG. Alpha HCG is same as the alpha subunit of TSH. So this alpha subunit of HCG acts like thyroid stimulating hormone. So that acts on the thyroid gland to increase the thyroxine. Now thyroxine production is met with, ban gaya, jitna thyroxine banna tha ban gaya. So enough thyroxine made, it gives a negative feedback, not positive guys, a negative feedback to the brain that there is enough thyroxine. So brain reduces the thyrotropin releasing hormone. That's why it reduces the TSH. So that's why in pregnancy, the TSH is reduced 2.5 versus 5. All right. Palma sign is rhythmic uterus contract. Kiss peptin is the neurons. Kiss peptin are neurons, facts, which are stimulating the hypothalamus. These neurons stimulate the pituitary by releasing the GnRH. Facts. You have to remember some facts. So Palma sign, rhythmic uterine contraction between 4 to 8 weeks. Chalo, which channel? I'll be here, man. Doubt. Okay, keep telling me the doubts, Aditya. I'm here for your doubts. I'm here. This PW, man, PW. We are going to discuss here live on YouTube. Yes, you're going to get it, all of you. Please tell your friends to come and attend the class. And going to be a lot of MCQs. I'm trying to cover all the topics, but do not miss out on this, please, guys, because it's important to do a quick revision. So I hope you're reading all the notes which we've given you. All those who have read the, the notes earlier, please come and revise with me. Those who have seen me in live classes also, please come and see me here again. And so that we can do a quick revision. Ask me a lot of questions. I'm always here. Triiodothyroid men, T3. Okay. Supine hypertensive syndrome. When the person is supine like this, the weight of the baby will press on the inferior vena cava, and that pressure on the inferior vena cava will reduce the venous return to the mother's right heart. So there will be reduced perfusion of the lung, reduced return to the left heart. So left heart will have less output. Less output means the mother will be having less cardiac output. She'll be not having much problem with that. she might be getting a little giddy because of that. But the lesser output means lesser perfusion to the fetus also, and that's what can cause the fetus to have hypoxia. The baby can have hypoxia 10%. Yes. हिंदी में नहीं हो सकती क्या क्लास? हिंदी में नहीं हो सकती क्लास? हिंदी में नहीं हो सकती क्लास? हिंदी में नहीं हो सकती, हिंदी में नहीं हो सकती क्लास? और एक ही बात को अगर 4 बार बोलोगे तो मैं तमिल में बोलने लग जाऊंगा. இனிமேலே நாங்க தமிழ்ல கிளாஸ் எடுங்கப்பா, ஹிந்தில எடுக்க கூடாதுங்கப்பா, இந்த மாதிரி சொல்லுங்க நீங்க. Guys, we have to have the medium instruction in English. I'll try to. देखो अभी जब आपने मेरे से पूछा तो मैं इंग्लिश और हिंदी दोनों में पढ़ा रहा था, ठीक है ना. मैं चाहता हूं कि मैं हिंदी में पढ़ाऊं, बट मेरे स्टूडेंट साउथ के भी होते हैं और नॉर्थ ईस्ट के भी होते हैं, तो उन लोगों को हिंदी आती है बट आपकी जितनी अच्छी नहीं आती. तो हम लोग सब भारतीय हैं, हम लोग को सबका ख्याल रखना है, तो बुरा मत मानिए. द एग्जाम इज गोइंग टू कम इन इंग्लिश, तो हम कोशिश करेंगे कि वी डिस्कस इन इंग्लिश एंड हिंदी, बट मोस्टली इंग्लिश. ऑलराइट. या how to prevent supine hypertension with Sudaprasamta. Please, all of this was discussed during this class. During pregnancy, tell the mothers to lie down on the left or lie down on the right, so that the weight of baby doesn't press on the vena cava. Maybe the transmission disconnection. So please see the recording of this. All right. Okay. Hello guys, we had a good discussion. Next time onwards, we I know the discussions before the MCA exam are more detailed. After that, we'll be coming to simple revisions before, because a lot of my MBBS students are listening to this. They want to stick to the facts which are important for their MBBS exams. So we'll have to make a distinction. But yes, till MCA exam, please bombard me with as many questions you have, because any exam coming up, we are discussing for them also. All the best, guys. Keep coming back for more. This is your PW favorite forum.